Hey Mo,
Hey, Ricky.
the doctor is in.
Yes, 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 we are. It
It's
is
Wednesday.
it's Breast Cancer Action Month.
It's Breast
And
Action Month. We are all
you
about
you
it.
know, I saw your email blast and I love what Touch did. And they took the awareness and X'd it out and said, enough of this awareness, it's time for action.
Yeah,
And it felt really powerful and empowering to me. But people, when you get diagnosed, you don't know where to start. Like, what is the action? Who are the people? Who are
right,
the players? And
right,
and it's such a
right.
timely conversation for us to have today.
It is, and Mo, I I've had so many calls, and I wake up every morning thinking, okay, who's going to get that call today from their
Yeah.
doctor? Yes, you do have breast cancer, right? And
Mm-hmm.
are we repeating the same stuff over again? We have new breasties every day. You guys see them.
Yeah.
And I didn't know what to do. I was very fortunate that I had a great navigator. And she said, okay, I'm going to bring all the docs to the table for you. What do you mean all the docs? Like, who are these people? But
Mm-hmm.
so many calls about, okay, well, I had the mammogram. It was funky. I got a biopsy. Now what? And they don't even get connected from and now people are getting the biopsy from the radiologist.
Yep.
Or the radiation therapist, and they're not even getting, the radiologist, and they're not even knowing that they have to find an oncologist. They're not getting connected. So we have these two badass docs on the line today.
I love it.
I know. So we have our Janice's favorite doc Janice flies from Atlanta to Houston to see Dr. Juanzetta Newman.
Wow. That says a lot when people fly in to see you, Doc. That people will fly for good care. I'm telling you.
Right. And Dr. Barbara, we love her. She's my neighbor. And I always see her on Zoom and not in Annapolis, which is crazy. But she runs this amazing business of mental health therapists, right? All kinds of therapists. And she's a breastie. So,
yes.
So we're going to break it down and talk about everything about who do you need to see? Like, where does it start? And it really starts with you, Dr. Newman, right? Kind of starts with your office.
Yes. So for us, my background is in general internal medicine. However, I have specialized in clinical cancer prevention for the last 18 years, right? So what do? We see a patient from beginning to end in one day. So the patient, be it has a lump, an abnormal mammogram from an outside facility, and brings that in for us to evaluate further. Or the patient has nipple discharge, skin changes, an inverted nipple, some sort of abnormality for which they are seeking further evaluation, or their outside doctor has sent them to us. So once we examine the patient, talk to the patient. And when I say talk, we do an extensive full history. As we were just chatting prior to us starting, it is so important to sit down and gather all those details at that appointment. What is that family history? What is the patient's personal history with regards to previous biopsies? Looking at those previous biopsy reports. Did they have atypia on those biopsies? Because so often patients are told, or patients report, oh, it was benign because it wasn't cancer. But in actuality, sometimes there were some cells that increased their risk of developing breast cancer that they may or may not have known about. So it's important to do all of that when you sit down with the patient initially. So we do all of that, examine the patient, then we send them over for diagnostic imaging. And by the end of the day, we sit down with the patient to look at and review all of the results from the day, including the preliminary results of biopsies. In particular, if there is lymph node involvement, we're usually able to talk and get that information that same day. So that
can you go back for a second?
Sure.
And break it down to the 5-year-olds for me. My filter now, Bella's 6 now. So I tell her, read stuff to her and she can understand it, and it's good. What is diagnostic imaging? Can you just explain that?
Okay. So when we send them over for imaging, diagnostic mammogram includes more pictures than that of the screening mammogram. So I should back up one segment before that. So when we find an abnormality on breast exam, we put a marker with a permanent, well, not permanent, but a marker such that the radiologist knows I found something at that area. We utilize an X to say this is a mass, or we use a circle, or I write tender, something to denote to the radiologist that there is a problem here. Can you magnify this particular area and tell me what is it that correlates with that particular area? So that's the first step in physical exam. And usually I tell that to the patient as well. Here's what I'm feeling, what my concerns are, and the possibilities of what that could be. So you set the stage for what the day might entail, such that the patient is already preparing their mind for the possibilities of what is to come.
You know, I love the fact that we have a program now where this sort of thing happens, because, you know, growing up, I was high risk and I didn't know it, and I didn't have a program to be a part of, or anybody who was really tracking my imaging or watching it very closely. And I think a lot of women still don't know that that type of service is even available to them. Like when we talk about know your family history, the whole reason is so that you can then qualify to be part of a program like this, where somebody is paying extra special attention. So if something is found, it can be found early. And so this is a really key point. You know, the point of knowing that history is so you can know what your level of risk is, and you can get the appropriate attention that you need. So you're not just home doing your exam wondering, well, I hope everything's okay. I know my mom had breast cancer and my grandmother had it, and I don't know about myself, but I'm a sitting duck. You know, there's more that we can do in today's medicine.
Or even people like Janice, who doesn't have a family history, but because she's my friend and she was my caregiver, she goes to get this analysis. You know what I mean? Of how thorough it is, you know? So she has, you know.
Yes, and it's your most vulnerable time. Yes. I tell patients, you go where would you want to be treated if we did find cancer? Because in that most awful moment, that is when the person has to go out and gather their mammograms, their ultrasounds, their path reports, their slides. And that is when the person is most distressed. Right. So we have this program and focus on both high risk, but we also see average risk patients that are very conscious about their health and want to be here in the event that they do develop something. So it is prevention at its finest, I would say, in that regard. So I get my mammograms here too, for that same reason.
Yeah. And one more thing you said that I think is really important is you said, you know, sometimes people have a biopsy and the results mean they're at higher risk. And it might not be cancer, but it's something that puts you at higher risk. And I can't tell you the number of women that I see that get a biopsy and I say, well, what were the results? And they come see me for the first time and all they know is they had a biopsy and it wasn't cancer. And I say, okay, well, what was it exactly? And if it's not cancer, they just assume it's benign, but there's another category called atypia, abnormal cells or things that are growing, proliferative stuff that's growing, but not cancer. That stuff needs to be watched closely too. So, you know, getting that history and really knowing your medical chart. You know, Ricky, for a while, we talked a lot about knowing all that medical history and having that chart follow you because it's so important.
Right. But you know what, you guys, when I look back too, so when I look back, when I had my first mammogram at 40 and they found calcium deposits. And I actually had them removed. I had surgery and had them removed because my boobs were too little to biopsy them. And without doing, like, they couldn't do the needle biopsy. But no one told me then that I was at risk for cancer. Isn't that crazy? And my mom had just had breast cancer about 5 years before that, but it never even crossed my mind that I was at risk for breast cancer. No one told. I went to like the best mammogram clinic in Atlanta, but no one said to look out. Fast forward, 10 years, look at me, right? But
so Dr. Monique brought out an interesting point, and I want to expound on that because it is so important to get your results, get your reports. Even if you don't know what they mean, bring them back to your doctor. When we sit down with the patients, we go over those reports because that factors into that risk assessment. So at the end of the day, it is great if we don't have to give a diagnosis of cancer, which most of the times we don't. But we sit down and calculate the risk to discuss what is the next plan of action. Do we see you once a year? Do we see you twice a year? Do we add in that MRI that Dr. Brown was just talking about as part of your army, if you would, of things that we could do to help prevent our early detection? So that is the whole goal. Nobody wants a diagnosis, but if you're going to get one, you want to get it at an earlier stage.
right.
So there are things that we could do in that regard of adding additional things and talking about medications that might help prevent them from developing breast cancer.
I just wanted to jump in because you guys are talking about history, but it's so important to have, you have to advocate for yourself, because if you don't have a doctor who's going to take you seriously, then you know, it's a problem. Just to say a bit more, you know, my grandmother died of breast cancer, and it could have been the treatment because this is way back in the 20s and, no, not the 30s rather, but she had so many x-rays to treat it that I think she died of the radiation. And then my mother had it. And so I was really looking for it. So I had an early, a need for a biopsy in my 30s, and it was, you know, benign, so they said. But I said, let me just keep on top of it. And so I asked for a mammogram. That didn't show it. And again, it was a 2D mammogram. So then I asked for a sonogram, and it took a couple of tries to get that and advocate for myself. And and I just knew, I just had a sense that I needed to keep looking. So finally, I talked, these were two white men who I was, you know, they were treating my mother actually. And so I said, well, let me go ahead and get treated. And so finally, I was able to talk to someone at the Penn Medical Building in downtown DC, who was actually a nurse, a Black nurse, who just happened to be next door to me. And I talked to her, and she finally gave me a slip for an MRI because no one else would give it to me. And that's when they found it. And they found it at stage 0. And then when they went in, it was actually had gone to stage 1 already. So my mother's wasn't found until stage 3. So I just felt really fortunate. But it's like, I want to tell people, trust yourself. So it's not just your history, but in navigating your own health, you have to insist that people listen to you. And we know the work with Black women is not stellar.
Yeah, and especially young women. That so many of our young women get dismissed. Oh, come back in 6 months. You don't need a mammogram. You're too young. And so that's what we're trying to teach, you know, with our For Love of My Girls, is to stand up for yourself. But think about this, Dr. Barbara. So when after I had all that stuff and we're talking about my treatment plan, and the day I met kind of all the docs, my navigator said, okay, do you want to see a psychiatrist? And I said, well, is that going to help my breast cancer? I don't, you know, and I did, but I mean, but the moment you find that lump, it's really when you need mental support.
Right.
Not like by the time you're at the treatment plan, you're already in the toilet, you know, you're already screwed up, right? So it's almost like, how do we build that into, I mean, well, I think everybody should have a therapist.
Okay, so change that dynamic a little bit in terms of the way you're saying it, because, you know, we try to normalize it, because when you get a diagnosis that is potentially life-threatening,
right?
You know, you are having a normal reaction to an abnormal situation, right?
Right.
And so you have to come to terms with that. And the way that I think of that, as well as anything that is really making a shift in your life in terms of how you see yourself, it's a grieving process.
Yes.
And there are stages of it. I mean, you're grieving the loss of your healthy self, right, and having to accept this diagnosis that, again, can be very serious. Right. And sometimes you cannot hear right away that, oh, you know, breast cancer treatment has come so far and all the good news, which is great news. But initially, you've got to deal with your emotional state that is in shock, in trying to absorb this new news. And so, you know, you're lamenting initially. It's like a very acute phase of saying, oh my God, you know, this is not good. This is horrible.
Yeah.
And you can, you know, again, feel frustrated. You can feel panicky.
Why me? Why me? Why this happened to me?
Angry, you know, downright angry even.
Angry.
I saw a patient on Monday, Dr. Barbara, and you're absolutely right in normalizing emotions. And she kept apologizing for crying. And I said, listen, this is not only the worst possible thing you hope to hear, but also you just had a divorce. Also, there's this, also there's this, all these things. Like, cancer doesn't happen in a vacuum. And I said, just take a minute and it's okay to not try to, it's okay to stop trying to stop crying. Right? She kept trying to stop herself. And I just stopped and gave her a hug. And she was able to really just sort of sit with it. And then we, you know, had our moment. And now we can take down some notes. Now we can ask some questions, because she couldn't hear anything else. She couldn't even move past all that wadded up. And had I, you know, just kept going, it's okay, it's a surgery, here's this, here's that. Yeah, the outcomes are better and the survival's better, but who can even process all that? You're absolutely right. But normalizing the trauma, and you said, say it again, because I think that people need to hear that again about feeling a normal thing to an abnormal something.
Yeah, you're having a normal reaction to something abnormal, something that is happening to you. It's not you, it's something that's happening to you. So you have to take that in. And it is, as I said, it's a shock to your system. So you got to go to a process of sitting with it. And then I don't care, you know, what kind of illness it is. I really do feel that at some deep level, you have to decide if you are going to fight for yourself or not. And that becomes a fundamental decision in terms of how you operate. And so when you kind of sit with the reality of it, and again, you can do that with support. Therapists can help you move through that kind of grieving process to get to the fight. I will say I had a client that I think about. She had breast cancer the first time her husband was living. She fought. She was like a stage 3 or something, and you know, she got through it. But then her husband died, and she got it again. She was not doing the self-care. She came back into treatment, and trying to get her to fight for herself was unfortunately a losing battle. She wouldn't. She went into depression, and she did not even get help. She would not. And, you know, if she were a child, you could call Child Protective Services, but adult services, you know, they're like, who's doing something to them? So they won't, if you're not taking care of yourself, there's very little you can do. And so that was sad because she did die of it.
Wow. So Dr. Burr, if it's normal to react to something that's abnormal, at what point does your normal change? Like, at what point do you know? Like, if you're depressed, and how do you know you need to get help? You need to get some mental or get some therapy. How do you know, like, what's a trigger or a signal to say, I'm now overwhelmed. I can't cope with this anymore. I can't get out of bed or whatever. Like, how do I say, okay, now's the time to go get some help?
So, you know, there are signs and symptoms, but, you know, isolation is a big one. You know, not, you know, feeling fatigued all the time, not wanting to get out of bed, not doing your normal activities, feeling apathetic. You know, again, the sadness, you know, can be overwhelming, but often people go into kind of a numbness. that they're just not doing, they're not functioning. And so if you're isolated and no one's checking on you, you know, that is a problem. So hopefully you have a child, a friend, you know, a pastor, someone, if you're at that level, who can reach in and pull you out. But for the most part, people will know I'm not doing well. And so having talk shows like this, you know, going to the doctor, having the doctor have a great bedside manner, and, you know, being able to provide them with group supports and those things really does make a difference. I know my nurse navigator was wonderful too. She got all my doctors together and she offered me the Breast Cancer Support Center. And again, that's a wonderful place that that people can go to for education support. So you're not alone. And that way you can get, you know, professional help and also the peer support that you need.
And maybe though too, so, you know, you have that first chemo and guess what? You can't get out of bed, or you are like lethargic, or you are, you know, feeling lousy. So I think that's where people can get into trouble too, because they really are depressed. I mean, the chemo is in combination with depression or sadness or whatever that is. And I think maybe that's why I find people get stuck. Like that first or second round of chemo, that's when we start to get the calls too. Like, I don't know what to do. I feel really bad. I can't take care of my kids. And so all the life things, like when people talk about, when doctors talk about side effects, they talk about you're going to lose your hair, you're going to be nauseous. When we talk about side effects, we talk about, can you cook dinner for your kids today? Can you go to the baseball game with your kids? Can you talk to your husband? Can you go to work? So we talk about it in terms of how's it affecting your life, right? And I think that's where we start to see, gosh, I think you should talk to somebody.
But those people who are reaching out, those are not the people I'm worried about. Those people are reaching out. There's an opportunity. It's you can call it a cry for help, whatever. They are reaching out. It's the people who don't reach out, who are used to taking care of themselves. And how many Black women do you know like that? You know, and they don't get the help, and so they suffer in silence and get worse. So it is important to have the doctor, whoever they're going to see for treatment, to be talking to them about their social life, about their social supports. So because the primary care doctors, my father was a primary care doctor, and I remember working in his office at age 14, and he taught me then that most of his clients, 60 to 70% of his clients, had emotional issues. And some of them were you know, the physical symptoms were actually emotional symptoms. And he had a psychologist who he referred to. And so that's how I entered into the field of psychology at that young age, just hearing that from him. So, but the primary care doctor is critical as a gateway.
Dr. Brown, I have a question for you. Based on your experience in working with African-American women, do you think that the medical community could serve better African-American community by standardizing or making it a practice to incorporating psychology or psychotherapy into the treatment regimens based on staging, or just based on the diagnosis itself, or based on your practice? What would you recommend?
So I do think that when we're talking about, the big word is value-based care, but even they were talking about it 20 years ago, about incorporating, you know, behavioral health, mental health into primary care practices. And so they have the little questionnaires that they have you fill out now, but it's really much better if you can incorporate someone who will just talk with you as a result. You know, psychiatric nurse practitioner, you know, counselor, you know, trained lay person, you know, anyone who's really a very good active listener, but the professionals can really assess for to see if there's a clinical diagnosis.
You know, I'll jump in and say I agree with you, Dr. Brown, in that we try to emphasize the fact that, at least I do, let me speak for myself. I try to emphasize the fact that chemotherapy is more tolerable than it's ever been, in order to help people with their fear that if they do chemo, they're going to die. And especially in Black women, there's this sort of reluctance to even consider it. And so by painting a rosier picture of, you know, how you should still be able to function in some regard, we try to help people understand that they can get through it. But one of the things that I think we could do a better job of is touching bases. You know, after I put that port in at that post-op, okay, what are your plans for your kids, for your this, for your that? Have we begun to make those plans, or are you just winging it? You know, like, how do we begin to put something in place? Because probably after that first infusion, you might not feel that bad, but after that second one, you know, then hair loss, now we got some extra fatigue. Now we start and really kind of, I think, and Ricky, this is something maybe for Touch to consider too, is sort of a plan, like a workbook of sorts that says, okay, who's going to be responsible for some of these things in life while I'm in treatment. And,
right.
And that way you have it written out, so you don't have to think of it when you don't feel good.
Yeah. Yeah. I know, you know, we say, well, it's really Haley Dinnerman's line, no one fights alone. So we try to get everybody to sort of get their care team together. But, you know, Mo, we have so many women that don't have their team. You know, we dealt with this woman a month ago who was living in her car, triple negative stage 3 during chemo. And we were able to, thank God, we got some donations to help her stay in a hotel for a few weeks till she could like move in with a relative. But her man put her out 19 years and living in her car. And she even said, the first thing she said to me was, you know, my breast cancer is one thing, but I have some issues because I was raped when I was 16. And so she had a lot of stuff going on. So I don't even know the, you know, I know like a pinpoint of what she had going on, but I said, well, I can help you with your cancer. We can try to get you a place to sleep tonight. But we know that people are living their lives and anything could be happening and bam, you get cancer.
I was going to say the pre-existing part is really important because, you know, the cancer on top of whatever trauma or what else has gone on in their life can really just tip the scale in terms of whether they are going to fight for themselves or not. I was reminded as you were talking about, I know I was practicing when the AIDS movement was first happening. When AIDS first happened, everyone was scared. There was no treatment, and I had clients who died from it. But in the process of their care, they had people who were paid for by the medical insurance, and they were their caretakers. They were at home with them. You know, they took care of them until they died. And I don't know, I was blessed to have a good support system, and I was my mother's support system. And I saw what she went through as she did the chemotherapy, and I was there for her, and she could rest and she could know that she was going to be taken care of. But there are so many people who don't have that. And do we have anything in our healthcare system now that is paid for where you do get that level of home care of people who really care about you and for you when you're going through it?
We don't. And that's why even like just the role of the navigator is so strong. Like we had our buddy Z on a couple of weeks ago, right, Mo? And Z was talking about how she's a navigator in Oakland. And she was talking about how before she can even get to start to talk about breast cancer treatment, she says, well, when was your last meal? Where are you going to sleep tonight? Where are your kids? So much is going on in our community that we don't see, that cancer just adds on top of, you know. But you know, even we see women though who have a good support system. We've been talking to a woman with triple negative. She has a great support system, great care, Sloan Kettering, and she's still having a really, really rough time emotionally.
So yeah, so she probably would benefit from talking with a therapist. Very much so.
Yeah.
You know, someone can meet her where she is,
right.
and then help her move up from there, help her move through the process. Because the grief process, there is kind of a going in, trying to regroup. And then as you go through the cycle, you can heal. And again, anger, sadness, you know, fear, all of that, to getting used to it. The longer you can sit with it, you know, it's like you can get used to it, and then you can adapt. You can start adapting and coming out of the bottom and moving up. But if you don't, if your bottom is where you're stuck, you have to get some professional help.
Yeah. All right, you guys, we're supposed to be talking about all the doctors. Go ahead, doctor.
Let me interject one other thing while you're saying that. I think it's also important to tell patients to call their insurance companies, because some insurance companies do pay for some of those services. And I'm mentioning that because I saw a patient a few weeks ago who was a team member, and I had no idea that we had those services because I only looked at it for childcare. But there's a whole host, a list of things that are incorporated in things that qualify for people to come in your home to help you with in terms of your activities of daily living. Some of those include childcare, but some of those have to do with taking care of elderly parents, as well as those undergoing treatments for whatever reason. And that cancer care treatment would fall under that umbrella. I had no idea.
Would it be occupational therapy? Occupational?
Yes. If the person's getting chemo and they need assistance with so many of their activities of daily living, and I only know because that team member told me, and she's been utilizing that service for assistance with her mom. But I thought it was just for childcare. So I think you need to call your insurance companies to say what services are available to me, because sometimes there are things that are there that you didn't inquire about because you didn't need them. So now that you're in need, just call and see, because you never know. I would not have known that we get so many hours per month of this service based on our insurance plan.
Wow.
I think that's something that needs to be talked about a bit more. You know, ACCC is a good place, the oncology social workers, right? Because I don't. This is the first I'm hearing of it, and usually we're able to connect our social worker with a case manager, let's say for that elderly parent or the corporation for aging or something. But it's always like a tertiary jump, where you got to call this person, and eventually you hopefully get it all ironed out so that you can have some respite care, so you can get your chemo and somebody's looking after dad or mom or whomever. But this is so really rich and wonderful, and I think we should lean into and explore this a bit more, especially Ricky, in the setting of this navigation that we've been talking about, and how we can navigate better, not just through the cancer program, but navigate through life, because those are two different pathways that the hospital doesn't help navigate as well, because it's so much need, right? Like there's a line to what hospitals are willing to do, but advocacy groups and navigators can help to bridge some of these gaps and really highlighting, okay, Blue Cross Blue Shield is going to cover these sorts of things. And have you asked your doctor or asked your plan about this? Like even just FAQs, you know, is huge.
Yeah. And even knowing you can ask, because when you're in that situation, you don't even know where to start, you know, like, and that's why we talk about all the doctors. So, you know, so let's talk about the doctors a little bit. So you go to Dr. Newman, she says, all right, I got to send you to Mo, right? Like, right. Like you need some surgery or so. So where is the decision made about your treatment plan? Like, so if you find the lump, it gets biopsied, there's cancer. So who's the doc that says we're going to either treat you with chemo, surgery, radiation? Like, where does that, how can we explain that to people? I kind of know the answer, but I mean, like, how does that happen? And Harper's like breaking Hill. Harper, what's your problem?
Dr. Newman, you want to go first, or I can? I think you can probably say how it happens in your center, and I can talk about how it happens in mine.
Okay. So in our center, it's a multidisciplinary approach. So what do I do based on the size of the tumor? If there's some lymph node involvement, I fill out the consult for the multi-team, and the patient will get that appointment like what you were talking about, Ricky. She'll get an appointment with the medical oncologist, the surgical oncologist, and radiation oncology. In addition, based on age and some family history and other risk factors, I'll add genetics to that appointment to coordinate all of those appointments in one visit. And I tell the patient, one of those doctors will emerge as the captain of the team.
Okay.
That is the person that will take the helm, and then that person will pass on the token or the pass on the care as you go through this process. But one of them will emerge as the team, but together, all of you will develop that personalized plan of care at that first visit. But you can give them a heads up of who you think that will be based on what we know already. Will it be the surgeon or will it be the medical oncologist?
Right. Right.
A little bit different in our center. We're a community hospital. And so sometimes I'll see patients even before their biopsy. So I'm already prepping them with what they might find and what we're going to do. Or they get the biopsy, which the surgical office ordered, and then they'll have a consult with us. And from there, if the guidelines, we go over the guidelines, we introduce the team and say, okay, these are the different members you're going to be seeing, but let's look at the guidelines. And it says, okay, this tumor is small enough where you might not need chemotherapy or you might not need it first. Let's talk about what that surgical plan could look like. We then have a multidisciplinary meeting called Tumor Board, and all of the doctors that patient is going to see are all at that table or on that Zoom. The pathologist going over the slides and the cells, the radiologist going over the imaging, the medical oncologist is there talking about what medicines they would give depending on the tumor type. So everybody has a chance to weigh in, but the patient hasn't met all of those people yet. There's two different sort of approaches to that, because sometimes patients can get overwhelmed by having a consult with every single person you're going to see all day long. Like we used to do that at Fox Chase, where you meet every member of that team. And then by the end of the day, you're kind of like, it can be a lot. Or you just sort of start with one and then we preface it and then you go to the next one. So there's different philosophies, but I always will try to include my social worker. Genetic counseling, we have a nurse practitioner who does that, and we'll try to combine it in that appointment to consolidate. And then there's a financial navigator that we have who will, if she can't come up and meet with you, she'll call you and start the process to start looking at what your finances look like. And that social worker is already starting to think about what are your psychosocial needs? Is there any food insecurity? So a lot of stuff happens behind the scenes that the patient might not be aware of. And I think it's really important for them to know that these things can happen behind the scenes and to ask about it if they're ever uncertain about what's going on.
But I mean, just even have to think about a financial navigator, really? Like you have to think about how much is this going to cost me and my family, right? Whew. I mean, well, yeah, when I went to have my mastectomy, I think I had to pay $1,000 just to get into the hospital or something, just to check in. What if I didn't have it? Would I have not been able to get my surgery that day?
Well, we have had in the past patients who show up for their chemotherapy and the bill is $10,000, right? And you're like, okay, wait, I have to pay $10,000 before I can get chemotherapy. And what you might not know is the drug might be $60,000 and they kind of cut it down to 10, but nobody told you. So you weren't able to plan, you weren't able to make a down payment, you weren't able to talk and get some grants. And so we tried to do a better job of preempting those things. So as soon as we know that's what you're going to need, our financial navigator is starting to look for grants, starting to figure out what are your copays going to be? What are your anticipated expenses? What can we apply for you? So having a financial navigator is is a newer model of things, but that person's job is just to help with the money, because a lot of times, the studies show that Black women in particular are less likely to finish these therapies because they're worried about money. If you're rationing your insulin for money, you darn sure going to be like, you know what, I don't need those last 2 rounds of chemo. Just take me to surgery. Let's get this over with, because that's expensive. And it changes the outcomes.
Yeah, I know. These are my $500,000 boobs, fake boobs. That's how much it costs, all the stuff, right?
For us, when we schedule a patient with possible biopsy, like diagnostic mammogram, ultrasound, and possible biopsy, they meet that financial person at the beginning, because with possible biopsy, oftentimes they have to collect a significant amount of money from them up front. So when I introduce the plan on the back end, you're going to sit down with the multi-team. Oftentimes, if there are any questions about finances, based on their insurance plan, they get assigned, we don't say financial navigator, but you get assigned a person, and that person can go line by line with you. If the doctor says, this is the surgical procedure, or this is the code, this is the cost you would have to pay. If the doctor says this is the cost you would have to pay. So at least the patient will know that information up front if that's what their desire is.
And you can't really choose. What are you going to say? Well, give me this one, but not this one, right? You guys, Sheila just came on. This is our buddy Sheila Johnson. She's going to do a commercial for her movie in a few minutes. So sit tight on that.
Sorry.
We're talking about all the docs that you see, you know, and
weigh in though, because how long did it take you to figure out who all the team members were for you? Was your head spinning, and how did you put it all together? And who's your primary person? How did you make those connections?
Well, I didn't know an oncologist was a cancer doctor when I first was diagnosed with breast cancer, because the first person I seen was a breast surgeon. And she is the one that told me that because it was stage 4, it was nothing she can do. So she said, well, I'm sending you to an oncologist because, you know, you stage 4, they don't want to give you a mastectomy. And I said, what's an oncologist? And I was like, oh, that's a cancer doctor. So yeah, I had to, because, you know, in the military, you go see one doctor and that's it. It's universal healthcare, you know, and it's usually a PA. So I had to adjust to knowing, like, even my plastic surgeon, from a breast surgeon to the nurses, to the nurse navigators, to social workers, if I needed. So yeah, it was, it took a lot of navigation to learn. Yeah. So.
But let's even be more prescriptive, you guys. So a medical oncologist gives you medication, so chemo, right? A surgical oncologist gives you surgery, and a radiation oncologist gives you radiation. So I'm just breaking it down for Bev. And so you need most of the, I mean, not everybody will have all those things, but I had all those things, right? So, but I mean, I think I didn't know that there are different kinds of oncologists, right? Yeah. I think the one thing too, I always hear too is make sure you go to a breast doctor, because so many people in these community hospitals, there's like the surgeon, he cuts everything. Or
yeah, and 80% of breast surgery in this country is still done by general surgeons. And it's not to say there aren't great general surgeons. Yes, really? But there is. Yeah, but there is a specialty. Fellowship trained breast surgeons are specialized in not just the surgery, but understanding the medicines. Because undoubtedly, as soon as I say cancer, the next question is, do I need chemo? And if they have a family member who works in medicine, they want to know what drugs they're going to get. So I got to know something about, you know, these things, and got to know something about radiation. How many doses? What are the side effects of radiation? Because if you're that quarterback for that patient, they're going to ask all those questions. And so you want to be able to talk about all of those things. But the way I explain it, Ricky, so that your granddaughter can understand, it's like a sneeze, right? You sneeze, surgery wipes your nose. Radiation dries it out. And so if your nose is runny, it dries out that runny nose. And then something's got to treat the particles that left with the sneeze. That's what medicine does. Or the easiest way, something treats the breast, something treats the rest. And then we break it down from there. What treats the breast? What treats the rest?
Wow. So Dr. Barbara, there's also different kinds of therapists, right? So can you explain that a little bit? And I know there are even oncology therapists, right?
There are people who do specialize in this. And I was going to say, I just had to comment, there's the genetic testing that I think is very useful. And when I had it, there was a test, and it was called Onco something, but it helped determine whether I needed chemo or not. and they were able to find that chemo wouldn't benefit me any more than radiation. And so that helped me make my decision, in conjunction with the team. So that was really helpful. But again, I think that because I do view breast cancer, I think it's important to know about the disorder, and having gone through it myself, it puts me in that unique position to have been in that space. But there are other therapists who are medical social workers, et cetera, who are regularly in the doctor's offices and regularly treat the vicissitudes, for want of a better word, of breast cancer in terms of the emotional reaction, and can do family therapy as well, can work with the families to help them help the client as well in understanding. So.
Wow. It's so complicated for a newbie. But I think that's why, Dr. Newman, your role is so critical, because you can break all this down for people, but not everybody has a you or a Mo.
I just tell the patient, email, send a patient message, communicate back to your team. If you have a question, it is the responsibility of your team to answer that question. There to break it down where you can understand. You're not the first person to ask those questions. So somebody somewhere has had to answer this, and we have had to problem solve about certain instances. So ask. There are no silly questions. And at 2 or 3 o'clock in the morning is when your questions are going to come. You send a message then when it's fresh in your mind, send that message, and then we will call you back, or we will send you a message back. But I encourage them to do that electronically or write it out and bring it with you when you come to the next appointment.
And that's
now I wanted to say one more thing.
Yeah, go for it.
Remember when I stated about the multi-team, and Dr. Monique was stated, you, Ricky, like it can be overwhelming, but I try to frame it to the patient. I think it's important, like we were talking about advocacy, you're meeting, this is your team. So this is a dress rehearsal for you in terms of these are doctors, but they may not be the right fit for you. So when you're sitting down having these conversations, if you're not gelling with that person, that is the prime time to start writing your notes and ask the patient advocate, I need a different medical oncologist. I need a different surgical oncologist. I need a different, before you embark on that journey, because that is the time, because you're going to be on this journey with that person for
you have to trust them.
So that is why I like that approach in that regard. Like you get to meet that person and say, we don't gel well, or, I didn't like that disposition, whatever it is. So you can find another doctor that's good for you.
Dr. Newman, who I found that approach to be very, very helpful for is the family members, right? Because people are taking off from work to be present and to be an advocate and to listen and ask questions. And if we can consolidate those appointments for the family members, that is a huge help, because if you got an appointment on Monday with the surgeon and then Thursday with the radiation oncologist, and then you got to come back next Tuesday with the medical oncologist, it's a lot for the support system. And so, one of the great things that came out of COVID was being able to do this all virtually. And when a patient comes to see me by themselves, the next question I'm asking, is there somebody we need to call for you? You want them on the phone? You want Facebook? I mean, not Facebook. You want FaceTime or Zoom? How are we going to reach? Who's your support if you have one? And if they don't have one, I go get my navigator and I say, okay, Jackie's going to be your person. She's sitting in that chair like she's your family member. She's going to ask me questions that your loved one would ask. And we role play, because somebody has to be there for you, And even if that person, even if you don't want that, that's okay. You can decline it. But I just want them to know that they don't have to go through it alone if they don't want to.
I would think that it's kind of standard of practice at this point to have integrated care and to look at not only the person and their symptoms and eradication, but also, you know, the person in their environment and what supports they do have. So
Right.
I can't see that anyone would do this in isolation at this point.
They do. And
Well,
and doctors don't
That's
ask.
not standard of care.
Every single day I see it. Doctors don't ask, you know, is there somebody you want with you? Or when they tell you to come to that appointment, I'll usually say, if you can, bring somebody with you, right? That way you kind of already know to bring someone if you didn't know. And it's still, you're right, Dr. Barbara, it should be standard of care. And I'm sure there's some checkbox somewhere that people are checking to say that they did it, but it's not as integral as you think, unfortunately.
Unfortunately.
Wow, wow, wow.
And you know, you say that I've been going to my oncologist for 13 years. And the first thing that she said to me was, if my bedside manner is ever bad, let me know. And I would go in and she would use terminology like, okay, HER2 positive. And I'm sitting there crying because I'm sitting there crying like, what am I positive for? You know, because I didn't understand it. Or even something as simple as stable. I'm like, what does stable mean? So I'm crying again. She's like, no, Sheila, you know. So just different terms like that being in the metastatic breast cancer world that, she explained to me. And that's the first thing she said. She said, if it's ever bad, let me know. And we've been jabbing for 13 years. So
Just keeping you here with us. So you guys, we have these lovely ladies here to do a commercial. So I promise them, and next week we're going to have them on the show for the whole show. But so you guys talk. I'm not going to talk. You talk about it.
I love it. The commercial. Well, I'll jump in. I'm Charmin Lee, and I had the honor of being the director of a film about Sheila Marie Johnson's life. And it airs on October 19th on BET Plus. And I have to say that it has to date been the biggest honor of my life. I love the fact that I get to do what I love, but then there's when you get to use your power for good, right? And this allowed me to understand really the power of the media, the importance of it, the influence of it. And I'm really expecting this movie to save some lives, period.
Great. We know it will. Well, we know her story. I can't wait to see how you interpret the story. And I did a project with Demetria McKinney.
Yes.
I dreamed Martin Luther. She played Coretta Scott King in this play that I worked on. So I can't wait to see her.
So you already know.
I know her.
Tell the people what you know, ma'am. Tell the people what you know.
Her spirit is like Sheila's spirit too, you know. So I think she's going to be so representative of our Sheila, who we love, and our audience knows her well. But we're so excited for this. So we'll do the whole show about it next week. They're going to bring some on, and then we're going to have a watch party. But
we appreciate you.
Because we want the details on how to watch. I mean, I want the details from start to finish. How did we get the cast? I want to know about the book writing process. We're going to ask you everything next week. But tell people again, so how can they access the film? How can they watch it?
So BET Plus, there's been a change in management over at BET. Initially, it was going to be on both platforms, but the main platform is no longer doing movies. So for our movie viewing, we all got to get BET Plus. Everything's moving towards streaming. We know that, right? So go and get your subscription now. And matter of fact, you can get that 7-day free. So wait and get it a little bit later if it's a thing. You know what I'm saying? No judgment. We just want to save lives, okay?
And then we want those numbers to be high on the premiere night, right?
Yeah.
We do. They earned it. Sheila earned it, first of all, for being so generous to give us her life story. And the actors, y'all, every one of them gave everything. My crew gave everything. Like every day, we started our day with information, and we all said at the count of 3, Sheila. So we stayed focused on what we were there for. We left egos outside of my set because we were there for a purpose that's bigger than all of us. So hopefully that'll translate when you see the movie.
And I had women come up and say, "Oh my God, I just scheduled my mammogram."
Girl, yes.
That was the purpose. I was just like, "Oh my God,
Yes.
this is real."
Yes. While we were on set, cast and crew. Yes, exactly.
So who plays your doctor? Who plays your doctor?
Girl, Dr. Contessa.
Yeah,
from Married to Medicine.
Oh, Dr.
Yeah.
We love Dr. Contessa.
Dr. Contessa.
She'll be on next week with us.
Yes.
So, yeah. But I didn't get to see her. I was kind of a little mad at that. But
that's okay. You're going to see her when you come to Atlanta in a week and a half. You'll see.
Michael Beach plays my dad.
Yes. And Michael will be joining us virtually because he just had a surgery. So he can't fly out. But Devon Franklin will be in the house, girls. Yes, I said it.
That's my love interest in the movie.
I'm just saying.
Okay.
I love it.
But that's all I'm going to say.
Yeah, right.
We'll see you guys next week. We'll see you next
Thank
week.
you so much. Thank you,
ladies. Thank you.
It.
All right.
Thank you for bringing this story to life. We love Sheila, and her life is so inspiring.
I love y'all.
And yeah, we're excited.
Thank you.
Okay. Bye-bye.
Mm-hmm.
Bye.
Wow. So
Sheila called me and said, "Can we just come on for a minute?" And I'm like, yeah.
I've been putting in the chat, and people said, "When is the movie?" And you'll see next week we're gonna discuss it again. It's October 19th. But I want to talk about how people can also reach you, Dr. Barbara and Dr. Newman, because it's been said in the chat here. Everybody needs a doctor like Dr. Barbara. Everybody deserves a Dr. Newman. Yeah. And so for people who may be in your areas, or maybe want to follow you on social media and learn tips and that sort of thing, how can they can get in touch and stay in touch with you?
So I am, of course, on LinkedIn, and our offices are in the DMV, and I have replicated myself about 70 times. So I've got a lot of therapists who work with people across the age span, and our main office is on Capitol Hill. And the phone number is 202-544-5440, Capitol Hill Consortium for counseling and consultation. We take all insurances. We believe in being affordable and accessible. And so we take public and private insurances. And it's 4 C's. So cccmentalhealth.com is our website.
Capitol Hill Consulting, 4Cs.com. Do you do virtual visits? So
I was just going to ask that,
Ricky. We do. We do in person, and most of our therapy now is virtual. Since the pandemic, we were 100% in person, then went 100% virtual, and now we're a hybrid. But we do not need as much space as we used to.
That's great. But that's great. So people who don't live in the DMV can call.
Yes, and with SIPACT, psychologists can now treat if you have SIPACT, you can treat in 40 different states.
Wow.
Mm-hmm.
So call her, you can feel her spirit and you know what, I think the other thing too is that you have breasty love. So, on top of just being the doctor, you get it. Right.
And we'll say we have started a wellness initiative. We have a holistic, more integrative wellness. And so we're starting to do wellness retreats. We're doing one in Jamaica in January.
I want to go.
Yes.
Awesome.
I send the information because it's really about reimagining your life and rejuvenating and really getting into your authentic space, which often can get lost in the course of day-to-day living. So.
Maybe we should figure out how to send someone on your retreat. I'll talk to you about that.
Sounds good.
Can you send the link to Dr.
I will. We'll send those. So how do I best send those? I guess
you can.
I'll send it to you, Ricky.
Send it to me, and I'll get it out to everybody. We'll put it in our.
Very good. Thank you.
And Dr. Newman, we know people come to you from out of town because Janice does.
Yes. So all you need to do is call 1-800-ASK-MD-Anderson, or you can log on to MD Anderson Clinical Cancer Prevention. You will find me there. All of my information is there. MD Anderson publishes our numbers, our emails, everything is there. You can send me a message. And the phone number for the clinic is 713-745-8040. or
713-745-8040.
8040 or 713-563-0050. And because I'm at 2 different campuses.
Okay. All right, I didn't get the second, but they can get you on the first one.
That's
So,
fine. Either way, it'll
Okay.
come to me.
Great.
Mhm.
Great. But you guys are awesome. Thank you
We're
so
grateful.
much.
Thank
And,
you for really
you know,
appreciate it.
we need to talk
Absolutely.
about all this more. And I know even we didn't even get to your preventative stuff, Doctor. You want to talk about and so we'll talk about that. We'll do that another day. But you need a lot of doctors, you need a lot of support. It's not just one doc that's going to take care of you. And if you're not getting this, what do you guys, people at the table with you, then you're not getting the right care. So, Ricky at Touch BBC, find me.org, and we'll help you get it. Because I'll call these guys, why, Mo knows I call her all hours of the day.
That's right. That's what I'm here for. I'm Dr. Monique Gary on all social media outlets. Follow me, message me. We're here for you. We'll connect you to resources and to these amazing providers, these amazing doctors and social workers, and we'll connect you to navigators through Touch the Black Breast Cancer.
Val. We got Val too.
That's right. That's right. Our guardian angel. But we hope this has been relatable and reliable, real. So we set out to do every Wednesday night here on blackdoctor.org. And we're so thankful for the platform to do it. We're grateful to our sponsors as well, Ricky, right?
Thank you, Genentech.
And we'll see you next Wednesday night, 6 p.m. on the
I'm
Doctor.
gonna come to your house, Dr. Barbara.
Oh, yes, definitely.
Okay.
All right.
All right.
Thank you.
Thank you.
There it
Have a
is.
good night.
Good night.
We love.